Hi, everybody. Welcome to our Wednesday webinar. This is the Association for Healthcare Denial and Appeal Management. And hi, everybody, and welcome to our Wednesday webinar. This is the Association for Healthcare Denial and Appeal Management. My name is Denise Wilson, and I'm going to be your host today. We're going to go right about 1 hour for our presentation today, and we're going to have about 10 minutes at the end for questions and answers. We will try to save 10 minutes at the end. I won't guarantee that we always try to, but if we don't get to your questions at the end of the webinar today, we do the best we can to answer those for you in either an email format or we post some answers on our website. So welcome, everybody. Glad to have you here today. Today we're going to talk about the CDI and coding team approach to denial. We're going to talk about how the best defense is a good offense. If you're new to GoToWebinar, just a couple of things that we want you to be aware of. You should have a screen that allows you to do some control over your experience today, a control panel. Within that control panel, you should have a gray bar that's called Handouts with a drop down there. And if you open up that little section, you should be able to download the slides from today. You can also submit your questions and comments via the questions panel. So you should have also another gray bar in your control panel that says questions. And if you have any questions about the content today, go ahead and enter them there. Those are the ones that we will attempt to answer for you if we have time at the end. Okay, a few housekeeping items before we get into the content today. We are offering free CEUs if you are an ADAM member. So you have to be a member as of today, which is June 16th, 2021, in order to get the CEUs today. You have to attend the live webinar for at least 50 minutes, and we will be checking that based on the report that comes out of GoToWebinar. So to be honest about your attendance, I do need to make sure that you have been connected to the webinar for at least 50 minutes, so I'll be checking on that. There is a survey that will pop up automatically for you at the end of the webinar. You also need to complete that survey in order to get the CEUs, okay? So you have to be an ADAM member, you have to be on for 50 minutes, you have to complete the survey. I email the CEU certificates out, and those are emailed out to you with whatever email address you signed up with. And those get emailed out in about a week, okay, because I do have to do all of those checks before I send your emails or your CEUs out. This is being recorded, and it will be on our website at www.ahdam.org. It'll be on our website within about a week. It's free to watch the recording. You do not have to be an ADAM member to watch the recording, but there will not be any CEUs available with watching the recording. And then our disclosure that there are no individuals in a position to control content for this activity that have any financial relationships to declare. Okay, from the survey, when you do the survey for the CEUs, you will be prompted to select your desired CEUs, and you can select as many of them as you want. So we have CEUs for ACTIS, for NARI, from CCMC for our case managers, from AHIMA, and also from ANCC, the American Nurse Credentialing Center, through the Northeast Multi-State Division Education Unit. That's where we obtain our CEUs for the nurses. So pick one or all, whatever you're interested in for the CEUs. And then I do want to tell you about our next webinar. We're going to go on a road trip called the Road to External Review. And that's going to be on Wednesday, July 14th at 2 p.m. And I'm going to be speaking at that one, as well as Bill Haynes, who is a managing attorney at Denial Research Group. We get asked questions about this all the time, about taking cases to external review. So that's outside, what we say is outside the court of the payer's opinion. It's outside of the internal appeals process that your commercial payers provide to you. A little bit about going to the administrative law judge level as well for traditional Medicare, because that is your first opportunity to go to external review, meaning outside of the insurance company's review process or appeals process. So that should be a good one. It is on our website right now. You can go there and register for it. I actually saw a few people notice it this morning and have already registered. So you can go there as soon as we're done today and get registered. A little bit about ADAM. It's the nation's only association dedicated to healthcare denial and appeal management. Our mission is to support and promote professionals working in the field of healthcare insurance denial and appeal management through education and collaboration. And our vision is to create an even playing field so that patients and healthcare providers can be successful in persuading medical insurers to make proper payment decisions. So we just want to get paid for the services we provide. And so we're here to help folks who work in this field to have all the tools and the resources and the education you need to help make that happen. Okay, I am the Senior Vice President at Denial Research Group, and I'm also President of ADAM. I've been in healthcare for over 30 years and mostly do appeals education these days. I do oversee some of the work that's done at Denial Research Group as far as our appeal writing. I have been to the ALJ hundreds of times and educated lots and lots and lots of healthcare professionals around the country on denials and appeals. The Association for Healthcare Denial and Appeal Management publishes and distributes materials on its website that are created by our members or invited industry subject matter experts for the benefit of all ADAM members. We do not certify the accuracy or authority of these materials. These materials are distributed and presented as research information to be used by ADAM members in conjunction with other research deemed necessary in the exercise of your independent professional judgment. ADAM claims no liability in relation to reliance on the content of these materials. The views expressed in the materials are the views of the materials authors, do not necessarily represent the views of ADAM. Any references are provided for informational purposes only and do not constitute endorsement of any sources. There are no conflicts of interest to declare for any individual in a position to control the content of this presentation. Our learning outcomes for today: at the conclusion of the webinar, the learner should be able to articulate benefits and strategies to engage in a multidisciplinary approach to denials management using both proactive and reactive methods. At the end of the webinar, the learner should be able to self-report identification of 3 main types of audits and denials, identification of 2 of the benefits of a close CDI code or collaboration, and identification of 3 specific strategies that clinical and revenue cycle professionals can adopt to support denials management. Okay, so introducing today's presenters. Christi is a registered nurse with over 16 years of experience. She's worked in emergency services, interventional radiology, which makes me happy because I hate doing interventional radiology appeals. I'm so glad to have someone who has expertise in that area. Cardiovascular services and administration. In 2013, she joined the CDI team. She did concurrent and retrospective reviews. She found great success in query writing, excellent capture agreement rates, and she was the first CDI educator for her health system. She currently works for Intersect Healthcare and AppealMasters, where she's a clinical appeals consultant. She's also our team lead for coding and clinical validation denials. She generates detailed and well-articulated appeal letters, and she presents cases at the administrative law judge level. So clinical validation and coding are her areas of expertise. Our other presenter today, Garnette McLaughlin, just ran out of room putting all of her credentials up there. Sorry, Garnette, I have to tease you a little bit, but we love it. Garnette began work in the HIM field in 2011. Before that, she had a background in IT and management. She has over 15 years of experience in management training and customer service. After she completed her Bachelor of Science in Health Informatics, she became an inpatient coder for an academic tertiary care hospital. Her primary coding specialty is inpatient, but she also codes ED, ancillary, outpatient surgery. She also has her doctorate in business administration, so we sometimes call her Dr. G. Her coding experience, expertise paved the way to transition the world of denials management, and her areas of specialty are writing winning appeals for coding denials and serving as an appointed representative in hearings. And she does a lot more than that at Denial Research Group. That's just a little bit of what she does. Okay, and at this point in time, I'm going to turn it over to Garnette and Christi, and I'm going to participate as the rest of you as being a learner today. And so,
thank you,
Garnette, I think it's yours.
Thank you. I'm just laughing at the credentials. Yes, I'm a collector. So as you can see by the picture I selected here, really coding and CDI need to work together to wrestle payers. Or at least wrestling payers is really what it feels like these days. For those of you who are directly involved in the denials management process, that is exactly how it feels, and you are about as tired at the end. So as you may have guessed from the introduction, we're here to discuss how the work of CDI and coding can really support a robust denials management program. Well, some of the specific strategies that we're going to cover in this presentation are very familiar because they support other areas. Some may not be aware that these strategies really actually also apply to denials management. And I'm going to do my best to control this webinar. So I'm going to apologize in advance for any technical difficulties. So where we're going to start is just doing a real quick tour of the different denial types that are out there. This kind of helps understand how they sort of connect to the proactive and reactive strategies that we're going to present today that you can use to address these different types of denials. And I keep messing up the slides, and I'm going to apologize now, guys. My deepest apologies. So there's really four main sort of areas of denials. The first is going to be medical necessity denials. So those things involve level of care, whether or not a patient should have been inpatient, whether they should have been in the ICU, those types of denials, whether or not a procedure was medically necessary or involved something experimental or investigational, or there was a lack of authorization for the services. Those are all going to fall under medical necessity type appeals. And so then we're going to move on to coding, and those are obviously things that involve potentially, we hope that it's not truly incorrect coding, or potentially abstraction errors such as the discharge disposition. The third main area is clinical validation, and I'm sure you've seen these, where this is where a payer is denying a diagnosis as lacking clinical support for the diagnosis. It's not valid from their opinion, and perhaps it's because we didn't use their preferred criteria. We'll talk a little bit about some of those later. And then the last area is technical administrative billing type denials. So these things would be out of network. There's a problem with the claim itself, or we didn't file it in a timely manner, something along those lines. And the other thing to know is that sometimes you'll get denials that are a mix of these different types of denials. For example, a RAC denial can question the assigned principal diagnosis, so that's a coding issue. And then they may also question the clinical validity of a secondary diagnosis. So that would fall more into the clinical validation realm. So you will see sort of combinations of the two. So just some quick look at some of the trends that are out there in denials land these days. Obviously, as more services are moving outpatient, we're seeing more denials of all types for outpatient. Again, more risk adjustment payment structures are out there, so we are starting to see those. more clinical validation denials, more denials that are actually based on queries, whether the query itself was invalid or leading, or the payer asserts a query should have been done and it wasn't. For those who deal with cert, you know, we see it all the time. We're still seeing denials based on technical documentation issues, lack of signatures, dates, authentication, specific required statements, things of that nature. And lastly, denials based on data analysis by algorithms. For example, there's one payer out there who shall remain nameless, although you probably know who I'm talking about, who uses an algorithm to analyze emergency department claims to see if what was coded on the claim supports the final level of care, E&M, that was assigned for that encounter, and it will generate denials just based off of that data analysis. So those are some of the things that we're seeing these days. So moving forward, I know that multidisciplinary approach is sort of a business buzzword. In addition to being difficult to say, I'm going to apologize in advance if I twist my tongue on that word, but we really just want to kind of take a simple approach. So a multidisciplinary approach is just moving past using only one department, such as just coding or just CDI, as the only defense to appeals management and denials management, and really broadening your influence to include other healthcare team members. As you can see, there's a bigger team out there, and there's a great benefit to bringing these people to the table, both on the front end in preventing denials and on the back end in actually working through the denial. Each of these groups really brings their own expertise and their unique knowledge base and their own perspective to it. So working cohesively and collaboratively together really allows you to go on offense and defense, and really beef up your documentation in particular. And so while today's discussion really is focusing on the CDI and the coding components and working closely together there, we don't ever want to lose sight of this broader denial management team, including your billing department, your finance and business office, contract management, your senior leadership support. Those are all going to be critical in the long run for success. And with that, I'm going to pass it over to Christi, speaking of collaboration.
Thank you, Garnett. So we're going to talk about what are the benefits to a multidisciplinary approach to denials management. So first and foremost is having a team that values the common goal, where everyone is educated and understands their role in the process and what each discipline brings to the table. When each team member understands that, then everybody can really work together for this common goal. Obviously, a multidisciplinary approach can lead to improved documentation, which is consistent, non-ambiguous, and clinically validated, like Garnett mentioned. A multidisciplinary approach also helps out your coding department tremendously, allowing them to easily follow the coding guidelines and the coding clinics with the improved documentation that's gained from these multiple disciplines working together. Next, a multidisciplinary approach lends itself to engage departments who are working together, recognizing and utilizing the talents and knowledge within each group's specialized field. So we all have a part to play, and typically each one of us is really good at playing that part. Utilize other people's specialized training and knowledge and let them be the expert. The end result, hopefully, is that you begin to see a change in your documentation, better quality, clinically supported, and able to withstand any appeal that comes your way, which leads to the ultimate goal here, which is utilizing this team approach to provide an easily defendable and heavily supported appeal, hopefully resulting in a decreased number of appeals overall, but also an increase, at least an increase in a number of overturns. So decreased appeals, increased overturns. And if need be, going a step further, a more holistic approach to any potential ALJ hearings or any other legal proceedings, such as arbitration, overall giving you the best opportunity for success at any level of the appeal process. Lastly, and I'm only going to mention a few here, is that when all of this aligns together and improvements are made with collaboration across these various sectors in your facility, the effects can have a trickle-down effect. Perhaps it's in hospital reporting scores such as Leapfrog or HealthGrade, maybe your Pepper reports, and other various quality scores. Overall, you'll be amazed at the impact of broadening your approach to include multiple disciplines and engaging in a team effort. So once we have identified this team approach, what are the methods that we can engage in for our denials management? We're going to go over a couple different sectors here, talking about what can we do pre-denial on the front end and what can be done post-denial on the back end. So first and foremost, I think it's important to note that CDI's role in denials management starts at the very beginning. When I did CDI, we were incredibly narrow, had a very narrow focus, mainly just focused on the financial aspect of what we could do to add a CC or an MCC, those types of things. Our department was not initially involved in our denials process, and so we neglected to approach our role in a preemptive manner. If you're familiar with the saying, begin with the end in mind, I think that's kind of a perfect mantra for the CDI department, but the end isn't discharge. The end isn't the coding department. Think past that all the way to where the claim gets paid or denied. So how can CDI departments change their focus on what CDI can do from the start to help with denials and appeals management? Well, obviously CDI plays a huge role in the quality of documentation, but most importantly, consistent documentation throughout the entire record. Consistency is key in defending a denial. Many denials are based on what payers refer to as inconsistent or conflicting documentation or ambiguous documentation. So we really want to make sure that the documentation while the patient's in the hospital, that it's documented consistently. Is your documentation clear? Can the diagnosis be defended by the documentation that's in the medical record? And if not, what can your CDI department do about it? Well, query, and query some more, something that all CDI departments are familiar with. But specifically, letting your queries work for you and not against you. It's important to consider, if you don't have this process in place already, that your queries are being maintained as a part of a medical record. And that's just not just the physician's response, but the query really in its entirety. So the questions that you asked, the clinical indicators that you presented, as well as the provider's answer. This helps you with, from a compliance perspective, showing that the diagnoses that the diagnosis that you're hoping the provider answers is well supported, and that the question that you asked the provider wasn't done in the leading manner. So really, you really want to show your compliance factor here. The last thing that you want to do is set your CDI department up for issues for compliant queries. And so if maybe compliance really hasn't been a focus of your department, maybe you want to spend some time investing in that and really educating your department to make sure your queries are compliant. As mentioned, providers thrive upon documentation that's not consistent. And this really pertains to uncertain diagnoses. We see a ton of denials for uncertain diagnoses that weren't carried through the documentation. Have your CDI specialists ensure that the diagnoses are either carried to discharge, so they're not just appearing on your H&P, or maybe you need to address it in a post-discharge query. Keeping in mind that if the provider answered your query in an uncertain fashion, that it's going to need to be readdressed, either issuing, usually issuing another query to your provider post-discharge. So is that something that your CDI department's doing? Are you following up on that? Do you have a process in place? Is that something that your coding department is responsible for? If not, then maybe you need to have a collaborative conversation with your coding department to find out who's going to be responsible for your post-discharge queries. I think there's a great benefit, and we're going to talk about this, in stepping out of that CDI silo and really working collaboratively with your coding department. The next is making sure your CDI specialists are aware of the difference between DRG validations versus clinical validations, as well as having knowledge about medical necessity. We're all aware of the coding guidelines that say that if the provider documented it, that it's supposed to be coded, but there's also a clinical validation element in play here, which is addressed in Coding Clinic 4th quarter 2016 on page 147. Payers are allowed to deny when diagnoses aren't clinically validated, even if it's consistently documented through the record. and your appeal to these denials is going to take much more than, well, the provider said so. So are you approaching the medical record from a clinical validation standpoint? Is that how your CDI department is approaching? Is there clinical support for the diagnoses in the medical record? If not, then there's always the opportunity to do a clinical validation query. We see, like Garnette mentioned earlier, hundreds and hundreds of denial letters where they mentioned that a query should have been sent for the clinical validation of the diagnosis in question. So don't be afraid to send them. They not only help in your appeals by preemptively giving what the payer was suggesting that you should have done all along, but also helps explain the provider's thought process for documenting the diagnosis. Next is considering whether your CDI department has a role in perhaps developing, adopting, or implementing facility clinical criteria. There's a lot out there, Sepsis 2, Sepsis 3, KDIGO, just to name a few. So are your providers all on the same page about which criteria is being used? Is your CDI department using the same criteria? If not, then perhaps it would behoove the health system to adopt various criteria, and CDI certainly can have a role in that as well. I think maybe perhaps the biggest area of CDI input on the front end is provider education. Certainly very huge for the CDI department. We're going to touch base on this later in the presentation, but I want to point out that it's not necessarily the CDI responsibility. That should consider that being a joint effort between your CDI and coding department. And if you have them, involve your physician advisors in that. There's so many areas for education. We talked about clinical criteria, and so ensuring that your providers are using that clinical criteria if you have that set up. Are they using it to diagnose certain conditions, and are they documenting those certain conditions when the patient meets the criteria? Educating providers of the details of their documentation really does matter, especially in terms of clinical validation. Again, gone are the days of the patient has a diagnosis because I said so. Payers are requiring so much more than that in order to approve and pay for claims. So just one easy example would be maybe the MEET method. MEET standing for monitoring, evaluation, assessment, and treatment. This provides adequate documentation to help support the provider's train of thought and the care that they provided. Additionally, are we making sure to educate our CDI staff members and our providers on the concept of medical necessity? I briefly mentioned that earlier. Does the documentation in the record support an inpatient admission? Do your providers and your CDI staff understand that? Do they know the implications that that has? So unfortunately, providers are being required to prove their decisions through their documentation. It's a hard concept to accept, and it lends itself to a lot of provider pushback, which is why education is such a huge piece of this. It isn't enough just to provide the information, but we as CDI staff have to help our providers understand the impact of their documentation or the lack of their documentation. And lastly, providing an education piece to the coding department. Like I mentioned, getting out of that CDI silo and really collaborating with your coding department. Break down the walls of your CDI department and join hands with the coding department in order to be successful. Who better to teach the coding department than the clinicians in your CDI department, but also remembering that there's a flip side to that. It's a reciprocal process, and as much as you can offer education to the coding department, are you willing to receive education from the coding department as well? What does that look like? Do you have staff meetings with your coding department, either monthly or quarterly? Do you have a process in place for that open communication process? Make friends with your coders. They are one of your best assets. So let's focus more on the back end. What can you do after the denial has been received? Well, first and foremost is your CDI department involved in perhaps writing your CV appeal letters or your medical necessity letters? If not, maybe that's something, something to consider. You should also consider whether your CDI staff has a role in legal proceedings such as ALJ hearings, or at least helping with the preparation for those hearings if they're not going to attend them. And I'd say one of the most important aspects of CDI's role in denial management is collecting, trending, and tracking denial data. working smarter, not harder. If you've worked in the denials appeals process long enough, you know there's typically no rhyme or reason for why one case gets denied for sepsis, but another almost identical case of sepsis doesn't. So there are certainly benefits to trending your denials topics. Know what you're up against in terms of potential denials. And then circle back around with that data and educate your CDI staff. We're going to talk more about tracking and trending of data, but very key here. Lastly, consider what role, if any, your CDI department has in payer contracts for your facility. We talked about clinical criteria. Is that something that should be incorporated into your contract? If it's already a part of your contract, is the payer abiding by that? Are they following the contract that you have in place? So lots of ideas to consider on what role your CDI department plays, both in the pre-denial process and in the post-denial process. I hope you see a theme embedded in these ideas. For the greatest success available to your facility or your health system, CDI should definitely not be working alone. It's a joint effort, not only approaching the denials and appeals process jointly with your coding team, but also with other disciplines in the process.
Thanks, Christi. Yeah, I can tell you as a coder in a larger health system, one of the pieces I always particularly loved was the clinical education that I was provided by members of the CDI team and the wider provider community in the organization. I always, as a coder, feel that my primary job is to do the absolute best job I can to tell the patient's story through the codes that I apply to the chart. And so for me to have a better understanding of their entire clinical picture helps me to do that. It also helps me to identify potential gaps in areas that perhaps, sorry coders in the audience, where we're going to have to engage in the keyword query. But that education for me was always something that I have valued very, very highly. So as Christi mentioned, it's all about working together. It's all about getting outside of your box. And I think coding in particular, sometimes we've been in the back of the medical records department and very closed off from any other members of the wider healthcare team. But we also have some expertise to bring to the table, right? As you know, a main concern of CDI, as with coding, our diagnosis documented clearly and consistently in the medical record. If we're not seeing that, let's make sure we're giving that feedback and then we are querying where it's appropriate. As a coder, one way to develop your skills is to be aware of capturing diagnoses that support medical necessity. Well, no, we know we don't code specifically for reimbursement. We know that there are certain things in the medical record we want to make sure we're capturing and coding as much as is supported in the record, and being aware of some of those peculiarities, say that 5 times fast, everybody, that are out there with payers. A good example of that, even as an inpatient coder, we see this. Medicare with valve replacements. This is a good example. So ICD-10-CM assumes if a patient has multiple valve dysfunction, that there is a rheumatic origin to that. Medicare does not pay for valve replacements for a valve that was damaged in a rheumatic condition. So if I see a patient who comes in and perhaps they're having a mitral valve replacement and they've got mitral valve regurgitation and tricuspid valve regurgitation, I might go ahead and preemptively query and say, physician, ICD-10 assumes this is rheumatic. Is it? And that's just one way of being aware of meeting some of these requirements that are out there. And Christi touched on this earlier, post-discharge queries. I know coders, the dreaded Q word, making sure that there is a process in place and that you have visibility into queries that CDI has already completed. What are you doing with those? Is the CDI worker following up on that? Is the coder reissuing that? How are those queries being handled? And also making sure you're communicating back to CDI if you're having to do a lot of post-discharge queries. For example, if you are perpetually querying interchangeable use of SIRS and sepsis. That's something to let your CDI department know that you're seeing so that they can do that. Most CDI departments don't have 100% chart review. So we're getting a look at some charts as coders, they're getting a look at some charts as CDI. So you always want to have that communication and bring those perspectives together. I mentioned it here too. We're not just going to work with our CDI friends, though we love them. We're going to make sure that we're working with our HIM operations department, depending on your organizational structure. We want to make sure that there is leadership support for what we're going to have to do, right? We know that if we have to do queries, if we have to follow up with CDI on concurrent queries that weren't answered, if there's missing documentation, operative reports, discharge summaries, provider office H&Ps for, say, same-day surgeries, that's going to increase DNFB, which always makes financial leadership very, very nervous. So we want to make sure that they are aware and supportive and understanding that we're taking these steps because we're really trying to prevent revenue leakage down the road through denials. I did mention, obviously, education to CDI. We want to make sure that we're keeping them up to date on what we're seeing in the coding world that's going to impact them. A great example would be first quarter, most recent coding clinic, 2021. We've got a coding clinic out there that talks about a patient with toxic metabolic encephalopathy secondary to acute on chronic hepatic encephalopathy. In the past, a lot of times, if a patient had that, it would simply be reported using the hepatic encephalopathy codes, so the hepatic failure codes, which, in my opinion, as a coder, really did not tell the complete story of what was happening with the patient. So this coding clinic now says if you have a provider who's specifically documenting toxic metabolic encephalopathy with that acute on chronic hepatic encephalopathy, it does take all three of those codes to represent it. Obviously, that can impact reimbursement, but again, it's all about telling that patient's story. So making sure your CDI team is aware of some of these coding clinics that are out there that could really change the way that we approach things. And obviously, when we have our updates to ICD-10-CM, PCS, or CPT, that we're informing them of things that we can use their help with. Post-denial, us coders, we can be very involved in writing appeals of coding denials. We can also participate in ALJ hearings or other legal proceedings. We are great data geeks, coders. We love our numbers, right? Letters and numbers, that's what we do. So we can definitely be involved in that tracking and trending of data, which we'll talk about in a bit. And also making sure that, within our coding department, we're taking things back to our coding staff. I know in some places I've been, I literally, as a coder, had no awareness of what was happening in the denials realm. And I would have loved to have known. It changed, moving towards and doing more work with denials. It has changed the way I code. So making sure that you're letting them know, what are you seeing? Are there problems with principal diagnosis selection? Get their feedback on it. Is it an education issue? Is there a documentation issue regarding maybe the reason for admission? Is that where the problem's coming from? Again, uncertain diagnoses, always an area we see payers pick on. And just, again, making sure we're staying in compliance with all of our coding guidance. And then, yes, we actually can, as coders, provide feedback to the people doing contract management for our payers. If we have payers who are blatantly not following coding guidelines or published coding clinic advice, that is feedback to get your contract management team involved in, because if that's going on, that's going to take a larger group of folks to be able to address it and hold the payer accountable for that. So that is a sort of some of the realm of coding, but there are more team members as we've talked about. And I'm not going to read these slides word for word, just in the interest of time, but if you don't have a physician advisor involved with your CDI team, and hopefully you're meeting together with the coding and you're all one big team, I highly encourage you, have a physician champion. There's simply no substitute sometimes for that peer-to-peer communication that can take place. And that way you can get that educational component that is so critical. That is a recurring theme here, making sure we're bringing data back to the providers. Providers are very data-driven individuals, and we're bringing that to them. And also because then we can make sure we're presenting a unified response. Providers are bombarded nowadays from every single side, right? So as much as we can provide one clear, unified message that sort of encompasses that, that's going to make it that much easier for the provider to do their jobs, which is to take care of the patient, and then also document that what they're seeing at the bedside. That's really the ultimate goal, is tell us what you're seeing, physician, and we will translate it into codes, and we will make sure that we get paid for that. So that is just a word about our physician and provider roles. Christi, as a nurse, of course, is going to discuss just a little bit about working with nursing staff.
Thanks, Garnett. As you can see by the slide, the focus here is really education, education, education. As a nurse, I was always told if it wasn't documented, it didn't happen. But there's so much more to nursing documentation as a whole. Instead of focusing on the legal repercussions, we should really be shifting our focus to more telling of the patient's story in details with the nurse's documentation. We see a lot of times that payers will utilize that nursing documentation in order to refute diagnoses, especially when there's conflicting documentation by your nursing staff and your providers. So as the staff caring for the patient all day long, 8, 10, 12 hours, nursing documentation really does matter. And nurses need educated on that. And not just nurses, but also CNAs as well. Their documentation certainly matters as well. Overall, the bottom line is you just simply cannot over-document. So I'm not going to go through all of these, and I hope that you see a recurring theme with the documentation that can be given to the nursing staff and how that translates into CDI hot topics and coding issues. But just to name a few, ulcer staging. Does your nursing staff document the staging of pressure ulcers? Is that readily available in the documentation? BMI is a huge one, and not specifically just the BMI, but also what's the aftermath of that BMI? What extra treatment are they doing for the patient to help support that BMI? Glasgow Coma Scale, if your patient has a neurological issue, are they capturing that? I can't tell you the number of denials that we see where everybody's like alert and oriented, and the patient has a neurological issue. Well, are they really alert and oriented? And if not, that discrepancy needs taken care of. Another big one that's up and coming is social determinants of health. It's such a buzzword now, and there's so much going on with that, but a lot of that can be found in the nursing documentation. And last but not least, I kind of want to hit on this because as a nurse, it kind of hits home for me, is that are we accurately capturing a patient's vital signs? How many times do we always see patients' respiratory rate is documented as 16 or 18? And we all know that that is absolutely not always the case, that even small variances in these vital signs can be crucial in defending arguments from a denial standpoint, or even crucial in preventing a denial in the first place. So giving that education, and then again, like we mentioned, circling back around and letting them know how their documentation is affecting your denials. If that means that you're involved in annual competencies, or you're reaching out to the nurse educators or nursing directors, have that open communication and that open relationship with your nursing staff and nursing departments. Next, we're going to move on to ancillary departments. Again, I'm not going to spend a significant amount of time going over each of these, but you can see them here. Again, with malnutrition, do you have a relationship with your nutritional department or with your dietitians? Their documentation is a key component in supporting the diagnosis of malnutrition. I have yet to see, either in my nursing or CDI or denials management career, a provider who independently documents on their own accord that the patient met Aspen or Glenn criteria. So are you utilizing dietitians use them. They're a valuable asset. Do you have a system in place, perhaps, where your electronic health record has a setup for alerts, potential alerts for those patients that are at risk for malnutrition or potentially have malnutrition? So utilize your dietitians to the best of their ability and really helping capture those diagnoses. Have that open relationship with them. And then again, on the back end, are you sharing that data, those trends with them on perhaps the volume of denials for malnutrition that you're seeing? Again, I mentioned the vital signs. So specifically talking about respiratory rates, I mean, your respiratory therapy, they document in the medical record too. Utilize them, have a relationship with them. PT, OT, SLP, there's a ton of things in there that they can be involved with in helping with, whether it's your functional quads, your hemiplegia, hemiparesis. Aspiration pneumonia is a huge target for denials. So working with these departments to really explain and educate them on the significance of their documentation and how that affects. Lastly, just want to hit on wound care, another huge one. They're an invaluable resource for your pressure ulcers, your DTIs, your other wounds. Can I hear it from the coding side about the long and seemingly endless list of codes out there for your wounds? So it's imperative that you're having that clinical evidence in the record to support the correct coding of these. Utilize them, share with them how valuable their documentation is and what a role that it plays in the quality documentation for coding and for denials. So education, both pre and post denial with these departments. Have that relationship, build that relationship with them. And I'm convinced that you will see the benefit of your clinical indicators in your record, not only helping code the charts, but also in defending your appeals process.
Yeah, absolutely. This slide is actually a really great example of CDI and coding working together. As Christi and I were discussing this area, one of the things I said was, well, in some organizations, wound care is structured in such a way that the providers that are in that team could be performing reportable procedures, even on the inpatient side, such as excisional debridements. And she goes, oh, really? Well, yes, some organizations, CDI doesn't necessarily look at procedures in particular, or again, your team may be set up with advanced practitioners as part of the wound care team who do perform excisional debridements. That's another big area we all know, right? Coders, we have to query that a lot. So that conversation was a great example of just having an exchange and going back and forth and us both taking something away from it. So again, these are all great topics of conversation that you as coders and CDI staff can have together, and then you can come back to these other members of the healthcare team and come with a unified message. So let me just move ahead. We've talked about this, guys, right? Using data in denials management. So I'm starting with this very, very scary diagram, but this is CMS's idea of where hospital coded and clinical data goes. And, obviously patient care is a big area for it, but it goes into an incredible number of places that you probably don't even realize: accreditation and certifications, quality reporting, utilization and case management, cost reporting, obviously appeals and denials, and the provider credentialing process. These are all areas where your data will go, and there are more than are represented on this chart. But I show you this to really also show that while what we're talking about really has an impact on denials management, it's also going to support this, which is that our ultimate goal is we're going to have a medical record that gives us the story of the patient. And so whenever we send it to any of these areas, it's accurate. It gives the information that we're looking for. So the same strategies that we're going to use are going to support the creation of that solid medical record, and therefore the associated data that really supports all of these different needs. So now that we've talked about that, let's just talk a little bit more specifically about the data that you want from your denials, right? really, you want to be able to answer some critical questions. What are they targeting? What are the most frequent denial types? What are the reasons for the denial? Where are you losing money as an organization? What's your return rate? How are you doing there? And so additionally, are you tracking the answers to these questions over time so you can identify any trends or changes in payer behavior? And in some organizations, your denials management may be off in a separate corner. As I mentioned previously, as a coder, I never received any information about denials unless I was asked the odd question about a chart I had coded. So you want to make sure that this information is making it back to the team, right? This helps just get everybody to be able to know where to focus their time and attention, and is that focus paying off? Is it doing what we really want it to do? Because we want to just make sure that what we're doing is effective, and if it's not, let's change it, right? All right, so in this I did just include, and these will be in our handouts that are available either in the handout section or after the webinar. They'll be available on our website. So from a data perspective, really keep it simple, right? If it's too hard to use, if it's too hard to maintain, it's too hard, it's just not going to work. It's not helpful. So for example, this is a report that just shows the core denial types, right? Medical necessity, coding, and how are they trending over time, right? That can help you identify potential areas where you need to look at some improvement initiatives, or you may need additional staffing to help you address this. And then the next example is just looking at our dollars by root cause. So this one looks at level of care not supported, a procedure or service that was not medically necessary, and comparing those dollars. We all don't have, unfortunately 40 hours every day to work on this. So being able to sort of know where should I focus some time and attention to really have a financial impact is a great question to be able to answer. And then lastly, again, trending that over time. So we can see, all right, we focused in on this level of care not supported. Have we had any impact, or is the payer changing in response to what we're doing? So it gives you a sense of where are you over time. And that's really critical to kind of gauging your performance and how are you doing, and what are payers doing in response to you, which brings us to we're getting to the end here, folks. Closing the loop. I love this meme because to me, it really drives home the main point. If you don't take the time to look at this and look at denials management and look at the preventative efforts, not just the reactive efforts, you're going to be spending more time and money to engage in firefighting, right? In denials management land, that means moving through the appeals process, which is very challenging, can be very resource intensive. So that's why I really do want to talk about closing the loop. So this is the loop as I think of it. This is the smaller portion of the loop. So as you kind of guessed from some of the previous sections, use your data to sort of engage in this continuous cycle. So as you picked up on now, right, we're going to respond to payer audits and denials. We're hopefully going to resolve those cases in our favor. And we're going to use that information that we collected in that process to drive our preventative efforts. Well, usually if we do that, payers are going to change their focus. They're going to shift their tactics, which is going to result in some new and different denials, which will then resolve. And then we'll change the focus of our efforts. You see where I'm going with this. In essence, it really does become an ongoing cycle. But the key part to remember is to make sure that you have this knowledgeable, multidisciplinary team armed with the information to engage in this complete cycle. As frustrating as it is to feel like we're continuously on a hamster wheel, you have to keep closing the loop. And understanding that, again, we're part of that broader picture, right, of denials management and revenue cycle. You'll notice this is sort of an infinity symbol, and I love that here. Really, the main focus is CDI and coding, as you can tell, have a critical role to play, and we've got to be on the same page and work together, but they can't and they shouldn't do it alone. So the entire team working together using proactive and reactive strategies is really going to give you the best chance to successfully manage the revenue leakage that occurs due to denials. We've covered a lot today, and I hope you found this helpful. And we certainly could keep going all day. It's a topic we're very, very passionate about. But with that, we're going to move on to any questions that are out there. And there is our office staff working hard, getting those answers ready to go. So if Denise will come back on and rejoin us. Bye, Denise.
Hi, guys.
Do we have any questions out there? It was a lot.
We do have some questions. So, yeah, let me pop this out so I can see it a little bit better. So we've got time for a couple of questions. Looks like we've had about a dozen or so come in. So we'll try to get to a couple of these questions. Like I said, if we're not able to answer them today, we will do our best to either send you a personal email, or what we've done recently is we have been posting the questions as a follow-up on our website. We will probably follow that method, because that has worked pretty well for us in the last webinar that we did. Okay, here's a question for you all. Should the coders ask clinical validation queries or choose not to code a documented condition if they feel it is not clinically supported?
Ooh, I'm going to field that one. By guidelines, if it is, as a coder, right, that the purpose of the guideline saying that if the provider documents it, you code it, is really to remove our judgment from the equation. So depending on your facility, you may have a policy that says, if in a case where you see a diagnosis that's documented you don't think is clinically valid, here's the process you should undergo. For example, reach out to clinical documentation integrity and work with a CDS or a CDI, whatever the job title is there, to take a look at that diagnosis and determine the next steps. No, we can't just simply ignore it and wish it would go away. I keep hoping for that, but we're going to have to figure out whatever it is for your facility. What do you do to deal with that? Whether it's the coder issues a clinical validation query, or again, working with somebody in CDI and perhaps somebody in CDI issues that query. It depends on your facility, but yeah, we can't just ignore it, unfortunately.
Okay. And one more question, because this is one we get asked all the time. What do you do when there is clinical validity, but the auditor has their own definition? Well, I have thoughts on that, but I'll let you guys answer.
Yeah, okay. Tough question. Christi, do you want to take that one?
Let's join effort that. Okay. I would say that there is nothing wrong with you appealing with your own clinical criteria, that there is not one specific clinical criteria over another that everybody is required to follow by. And so I think that's worth pointing out in your appeal letter, that you can certainly state, if, like we discussed previously, that if your facility or your health system has a process in place for clinical criteria, you can certainly point that out in your letter and state what your criteria is that your health system uses. But by no means should you not appeal just because they're using a separate criteria or a different criteria than what you're using. And there are plenty of overturns, even if your criteria doesn't match. I think it really comes down to a well-articulated letter, really supported with whatever criteria your facility uses or whatever you go by. Anybody else want to chime in on that one?
Yeah, I want to add too, this is a great example too of where other people's knowledge and expertise can really come into play. A good example, sepsis in the state of New York. There are several states that actually have legally defined what sepsis is and how you identify sepsis, because obviously we've had too many tragedies where sepsis was not identified and intervened early enough. So that is a good example of where, if you are in one of those states that does have that, you would want to make sure that you're bringing that into your appeal. So you'd have to know that, though. Somebody else with potential legal knowledge would have to be feeding you that information, is a great example. So yeah, I'm with Christi. absolutely no reason. Definitely appeal it. Definitely argue it. I'm just not a big fan of stepping on provider autonomy. I mean, if they were clear in the record about why they thought this patient had that condition, to me, I'm not going to step on a provider's autonomy. But then always look at some other resources that you could potentially bring in, such as a legal argument, if that might apply in your case too.
All right, absolutely. Okay, we're at the end of our hour today. Thanks everyone for attending. As soon as I sign off, your survey should pop up, so make sure you complete that if you want the CEUs. And sign up for our July webinar, which is, as I said, we're going to take a road trip, the road to external review. And on our last slide here, this is how you can reach any of us. You're welcome to email any of us with questions you might think of afterwards. We have captured all of your questions in our GoToWebinar screen today, so we will put some answers together for you. Since there's so many of them, we'll probably do a little follow-up question and answer that we'll post on our website within a couple of weeks. So thanks everybody. Enjoy the rest of your day and the rest of your week. Have a great summer. We'll see you in July.
Thanks everyone.
Thank you.